You ready?
I'm ready, mate. Always ready.
Always ready.
Hello,
We are
mate.
born
I'm very
ready.
good.
And
Yourself?
yeah, I am great, thanks. And I'm excited about today's podcast. Associate Professor Ziad Nehme. Now, he knows a thing or two about cardiac arrest.
Z is incredible, mate. I think, I knew Z from his early days when he first started studying paramedicine, and he was involved. And I think one of his first research papers was on paramedics and bag valve mask
Yeah,
ventilation by hand. And did they think they knew what sort of volume they were administering, or something
yeah,
along those lines? And I think it was very clear early on his focus was going to be research, and also he is an extremely articulate person. If you give him all the data and allow him to speak about it, he's incredible with it. So we were very fortunate to have a chat with him and speak about all things research, and especially in relation to cardiac arrest.
yeah. No, you're right. I remember studying alongside Sid. That paper was called So You Think You Can Ventilate. There was a popular TV show at the time, said So You Think You Can Dance. So that was the start. That's
Oh
20
yeah, we
years
can dance,
ago.
boy.
Yeah. And he puts on a bit of a dance too, but that's what it was from. So you think you can ventilate. But people got that wrong. So that
Yeah.
was 2008. It's 20 years ago, 18 years ago. And since then, yeah, he's become probably one of the leading cardiac arrest researchers in the world, which is why Victoria is the second best place in the world to have a cardiac arrest. So if you're not in Denmark, be in Victoria. Isn't that right?
Yeah, that's what the evidence shows. So
Yeah.
certainly our recent cardiac arrest results have been very positive. So, and a lot of that can be associated with the research and the training that is being pushed and directed by Ziad. So well done, Ziad.
Yeah.
So great little chat, really worth listening into. So I encourage everybody to nestle in, go get your cup of biscuits and your Tim Tams and a cup of tea, and get ready to watch this episode.
Yes, yeah, absolutely. Look, just one thing that I found very fascinating. We talk about the chain of survival, and I think in the past, and people focus a lot on the sort of intra-arrest ALS side of things, but there's probably more gains to be had in that sort of pre-EMS contact phase, and some of the stuff Sid talks about, turning every arrest into a witnessed arrest, I
Yeah,
mean, yeah, that's gold. So, yeah, tune in. Play the
tune in.
song.
The
Can we
music,
say
mate.
that
That's it.
enough
Good on
there?
you, mate.
So
Bye.
play this. See ya. G'day everyone. This is exciting. Shep will join us in a sec, but I've got here with me today Associate Professor Ziad Nehme. How are you, mate?
Good. Nice to join you.
Yeah, thanks a lot for joining. Look, if someone were to have a cardiac arrest, they're best to have that around you, isn't it? I mean, that would dramatically increase their survival. Not only are you the Director for Research and Evaluation at Ambulance Victoria, you're the Chair of the Victorian Cardiac Arrest Group, is that right, the back
Correct.
car?
Correct.
And a practicing paramedic.
Correct.
So you drive the research, you analyse it, you implement it. But where do you live? Could I move next to you just when I'm getting a bit older,
Well,
just to be safe?
I'd say don't suffer a cardiac arrest near me, but I think if you suffer a cardiac arrest in Victoria, you'd fare reasonably well. And I think our recent results in the VACAR annual report for 24-25 sort of highlight just how well we're doing as we're heading out of the COVID-19 pandemic, where most systems, I would say, not just in Australia but around the world, obviously suffered a reduction in survival due to very different systems of care during that time. The absence of public involvement in the sort of early parts of the chain of survival, because many of us were in lockdown, certainly in Victoria. And as those systems start to return to normal, we're starting to see more involvement in community and obviously better access to public access to fibrillation, and therefore better outcomes. So, yeah, I would say don't have one near me, Alex, but you'd fare pretty well if you're in Victoria.
Yeah. Now look, it was meant as a compliment. Don't have a cardiac arrest, anyone. No, but mate, that report is fantastic. So, for anyone who hasn't read it, and this would have been all over social media as well, and I think it's well known across the world, like a tiny little state down southeast of Australia, they seem to produce some pretty impressive numbers. And these numbers are getting better every year, mate. I'm not sure. In 10 years' time, no one will die of this if you keep up your good work. Brother, just give us an overview of, in Victoria, how many have a cardiac arrest, how many of them get, I guess, paramedic attendance, and how many of them are back at work in 12 months' time. You know, that's the key metric, isn't it?
Yeah. So I guess to give you some background, we've been monitoring cardiac arrest in Victoria for almost 2.5 decades, since 1999. We do that because it's a Global Resuscitation Alliance recommendation. We think that, international experts think that EMS have a pretty important role to play in the early response to cardiac arrest, and in most part the differences between life and death can really be determined by the EMS system and early action by bystanders. And so every 12 months we put out an annual report that really sort of highlights our successes in this space. In the last financial year that we attended 7,500 cardiac arrests. About 45% of those or so were treated by EMS personnel or paramedics. In the overall cohort, survival to hospital discharge was 14%. And in the Utstein cohort, which represents patients who are witness to arrest by bystanders and present with initial VFVT, their survival was 44.4%, which is a pretty impressive result for us. It is the highest result in our history. It sets us on the top of the ladder, if you like, nationwide, and probably second best in the world against EMS systems that routinely report this metric in their annual reports, and it's probably only second to the Danish, who are doing extremely well with a survival rate just above 50%. So it's a good result. It's always nice to have very high survival for bystander witnessed initial shockable rhythms, but it's also an important time to reflect that there are 7,500 cases, 21 cases a day in Victoria, and that statistic that 1 in 10 survive is still relatively true, which means that this is always going to be an incredibly heinous condition for those patients who are amenable to treatment, certainly in the way of their initial rhythm being VFVT and are witnessed. Then we're doing better, and overall we're doing better, but we still have a long way to go, obviously, to end the catastrophe that is cardiac arrest outcomes more generally.
Yeah. Now, fantastic. And you were saying that you've been monitoring this sort of for 2.5 decades, and along that 2.5 decades, there's been implementation of various things. And I guess, if we think of the chain of survival and these things that come in and sort of improve the care of patients with cardiac arrest, they fall in different parts of that chain, if you like, whether that's earlier defibrillation or better drugs sort of intra-arrest. I think anyone who comes to this space sort of fairly new, they would think it's all what happens on the ground with the bedside, what's the stuff you're pushing into the vein that's going to improve survival. But as you can attest to, and it's a system thing. Hey, would you maybe sort of talk to that in a sense, like, how important is the system, and out of all the things that's been implemented, is it any in particular that's shown more improvement?
Yeah, I think a terrific question. Optimised chain in the chain of survival is the early response, the recognition and the early response chains, the first 3 chains of the chain of survival. In the future, we're probably going to look at cardiac arrest completely different. We're going to have wearables that might even help us detect cardiac arrest, and that might start shifting unwitnessed cardiac arrest, which is fundamentally a devastating, catastrophic condition where no one really survives, to a witnessed cardiac arrest, because they're wearing devices or technology that can help recognise arrhythmias early. That might be able to activate the emergency medical system. So that chain has probably the biggest way to go, if you like, with new innovations that are coming into the market. We still need to do a lot of research in that space to understand what the potential is, but that could dramatically change the landscape for cardiac arrest patients. But if you ask me today, what is the most important action that people can take across the chain of survival, it must be public access to fibrillation, because what we see in our data every year is that bystander CPR is plateaued. We have not seen drastic improvements in the community doing bystander CPR. That's largely because most people who can survive are already receiving bystander CPR. But where we can see dramatic improvements is the use of a public access defibrillator. And I would say that the current model that we have, where we put up defibrillators on walls, like an artwork, is not the right model to have. That's a model that might be useful in public locations, and we need to see them more often in public locations. We need to see more equity in the distribution of AEDs in public locations, but we still have a long way to go when it comes to actually getting these devices into the homes of people where they're actually having a cardiac arrest, and doing that in such a way that you can actually deliver a shock before paramedics walk in through the door. And if we can do that, then maybe the statement you made at the start of the podcast around, is anyone going to die from this condition might actually be true, because you could, very dramatically change someone's outcome by getting that defibrillator in through the door and landing a few shocks just before the paramedics walk in. So those three chains are by far the most important, but the one that is least optimised, where we've got most potential, most bang for buck in this space, has got to be that early defibrillation one. I think you'll see in the report what our colleagues are doing on the ground is phenomenal, and might take my hat off to their expertise, their skill, the quality of CPR performance in Victoria coming out of the COVID-19 pandemic. We've really polished our shoes when it comes to CPR quality metrics. Our intensive care paramedics are intubating now with incredible accuracy and first pass success, which is a fantastic result, but we're recognising rhythms much earlier than we had been. We're shocking patients much quicker than we had been, and in fact the biggest improvement in the last 12 months was the proportion of patients receiving a shock, that could receive a shock in the first 2 minutes after paramedic arrival, increased by 6 percentage points, and that was exactly the metric that we wanted to try and drive in the last 12 months, and we're starting to see that. So our healthcare professionals, at least in Victoria, are well optimised, pre-hospitally and in hospital, but we've just got to lift the game when it comes to community input and action for cardiac arrest, particularly around early defib.
Yeah, fantastic. Shep,
hey, Shep.
join us.
My apologies for being late, had a little bit of issue logging on there, but hey, I joined in on that conversation just then, Z, and you've got some wonderful stuff to talk about, not surprisingly, mate, a wealth of knowledge there. What about, and I know this happens in other countries, providing AEDs for people like police officers or the postman or, the guy that stands at the children crossing with the stop and go sign, mate, putting AEDs into those areas. Yeah. Is that something that's feasible, and do we expect that having those would increase the community response and increase or decrease the downtime before the first shock?
Yeah, Matt, it's a good question. Are they feasible? They're highly feasible. Do they work? We know they work. We know they work from the international experience, and I think I'll give you this comparison. Victoria is really one of the only places south of the equator that responds firefighters to cardiac arrests. And that initiative started in Victoria in the early 2000s. We know that the impact that our firefighter colleagues can have on not just patient outcomes, but on the quality of resuscitation. We have a paper recently showing that the most important factor determining whether you meet those guideline consistent benchmarks when it comes to CPR quality is whether fire personnel present on scene. That's an incredible endorsement of their professionalism and the work that they can do. And we know that they contribute not just to short-term survival to hospital discharge, but we've actually published work that shows that them shocking patients first is actually associated with some improvement in long-term quality of life outcomes. And so that model of care can extend to just about any other professional first responder. I would sit here as an advocate of resuscitation and cardiac arrest to sort of implore other first responders to take on the very simple tools to resuscitate patients like CPR and AED. We haven't seen those things happen everywhere because there are other, obviously, organisational related pressures for those organisations, and obviously the police have some of their own challenges to address, and at this stage we haven't seen too many police organisations take part in responding to cardiac arrests early, certainly in the Australian context anyway. But even from a firefighter perspective, we're not seeing uptake of firefighter first response across other states in Australia, and I think that is really, really sad, and somewhere we can make huge improvements on a national scale. On the point of firefighter response to cardiac arrest, I'll just say that for the first time in 20 years, we in Victoria have been able to finally bridge a really important gap that we've had for a long time, and that is that if you suffer a cardiac arrest in metropolitan Melbourne, you get a response today from a Good Sam, a smartphone activated first responder, a firefighter first responder, and of course you get multiple vehicles responded from an Ambulance Victoria perspective. But we didn't see that same response in rural areas in Victoria until very recently, as we've rolled out the Fire Medical Response Program. We've got 39 brigades signed up to that, and I thank our firefighter colleagues enormously for them putting their hands up and endorsing themselves to be part of that cardiac arrest response, because we know it'll save lives.
Yeah, nice.
Fantastic. What about the Uber guys that are rocking around the city with food? Couldn't they just drop off an AED? I mean, it's quicker sometimes to get a Thai meal at my door than I hear people complain about ambulance.
Dropping off the AED is certainly one part of the equation. The most important part is actually getting them to use it, and so I'd hate to think you could just drop it off. But we know that people arrest in places where AEDs exist and they still don't use them. And so one of the things we've spoken a lot about is getting the right person to the scene, and some of the science that we've published in the past shows that if that person is a medical-based responder, a healthcare professional, then the person is 40% more likely to survive. And a lot of that is driven by an uptake in public access to defibrillation. So it's one thing is getting the AED to the scene. The next thing is actually getting the right person to have it. And you would both know about our first responder shock trial, which is about arming Good Sam responders with ultra-portable AED solutions. And later this year, hopefully, we'll have the results of that trial published, which I think is definitely an avenue that we're interested in building up further.
Yeah, nice. We'll have to have you back for that.
So we spoke a little bit there about community response and reducing our downtime and getting our first shock away. From my perspective, I'm more interested about what's the progression for paramedicine. I think I've heard recently discussion with regards to dual sequence defibrillation. There's been some research with regards to that, and obviously it's not progressing here in Victoria at the moment. But what are your thoughts on dual sequence defibrillation?
Well, I've got my little friend here. I told Alex I've strategically placed my little friend over here, my little Panda. I'm going to speak about Panda in just a moment. But look, double sequential defibrillation and vector change defibrillation are both techniques that I think ultimately will live in every clinical practice guideline in the world. There is some conjecture at the moment just about whether the dose VF trial results on their own stand as unequivocal proof that these interventions are in fact useful. It'd be nice to say the interventions require very little training and they can be implemented anywhere with virtually a PDF document, but the reality is that they do require training, and for an organisation such as Ambulance Victoria that prides itself in the choreography of its arrests and the quality of its CPR, what we do need to make sure is that if we implement those sort of techniques, that the workforce has the training to implement them well with very little hands off chest, and they actually can nail those techniques without the resuscitation quality deteriorating. And so, look, I think it's just a matter of time where we start to see additional science. There's a number of double sequential trials and vector change trials in various forms that are already taking place around the world. I think that those trials will be critically important for this space in the next few years. Look, I think, depending on some of the observational data that comes out after the implementation of these techniques, I would think that these are interventions that would live in almost every clinical practice guideline, and it'd be just a matter of time before they take place. The point of defibrillation science. We had the decade of mechanical CPR. We had the decade of therapeutic hypothermia and targeted temperature management. We had the decade of drugs, advanced life support drugs. And now we're looking down the barrel of the decade of defibrillation. That's probably, in my mind, probably the most exciting decade for paramedics. Previous years, I think, have focused predominantly on things that are less sexy, but I would think defibrillation science is, speaks to the heart of most pre-hospital care providers, and I think we'll see that in many forms and not just double sequential.
Very good.
Fantastic. Can you guys see my screen here?
Certainly can.
Yeah, good. So this is from your most recent VACAR report, just to what we're talking about. So here's the 6 chains of survival. And, as you were saying, there's been a lot of work in this little chain here, and would it be fair to say that we've optimised that as much as we can? And even if there was a drug or an intervention around that improved things very slightly, there's more gain to be done by sort of strengthening these chains here. So earlier activation, you were talking about sort of, wearable devices to make every arrest witness. That's a fantastic framing. Get on the chest, call push shock, come on people, and then defibrillation, all sorts of ultra portable. So how do you start improving this defibrillation?
Well, that's a can of worms, I think. So one of the huge interests that we've taken in Victoria is the idea that defibrillation efficacy is really a product of impedance, transthoracic impedance, and reducing transthoracic impedance improves shock success. We know the fundamental basic science literature would support that, and we know that in the early days, if you turn your textbooks back to the 70s and 80s, almost all of that literature using monophasic defibrillators would support the idea that putting firm pressure on the paddles reduces transthoracic impedance and improves better defibrillation outcomes for patients. We had thought that double sequential defibrillation works in exactly the same way, in the sense that when you place defibrillator pads in the AP position, they generally deliver more current to the heart, and usually as a product of less impedance. That is, that it has less impedance when you're delivering a defibrillation vector straight through the chest, as opposed in the typical AL position. So we think that may be one of the mechanisms for why it's so effective, but we still need to do a bit more work there. And then outside of those two things, we're talking about obviously current delivered using multiple shocks, and also reducing impedance. And the third thing is really about what the optimal vector is from the start of the cardiac arrest. So when you walk in, should you put your pads in the AP position, or should you put them in the AL position? And then when is the optimal timing to change those positions? And that's a question that's not been adequately answered, and I think we'll see clinical trials in that space. We might even dip our own toes into a clinical trial in that space over the next few years with our national colleagues as well. And then, of course, the question around the optimal amount of energy and current is still, I think, an unanswered question. There's a lot of belief that maybe the defibrillator just needs to deliver maximum current and not undergo a period of sort of impedance compensation for patients, and that maximum current may in fact be more beneficial than what the defibrillator is currently dishing out for patients.
It sounds like quite an obvious lead into a trial, doesn't it? Sort of the anterior-posterior pad placement from a start in comparison to normal pad placement. I think Alex is texting me now saying, "Shep, let's get onto this. Let's start organising this research."
Well, we're already talking about it, and look, while I'm a bit tight-lipped as to the details of such a trial, I can tell you it's not just the Australians that have interest in this, but everybody around the world is now starting to ask the question: well, if vector change is useful, then what is really the optimal position of pads? Now, there's an issue, right, with AP placement. The issue is that when paramedics walk in, they've got to turn the body, they've got to properly remove whatever clothing is on that person, particularly to access the back. That adds critical time. I think it's probably a seconds game, but it might actually be a minutes game. We don't really know. And that in itself might offset any of the potential improvements that AP placement might offer. So we've got to be really careful, and we've got to make sure that if we're going to introduce this intervention, it's done in systems that have really good optimised CPR performance.
It's like I'm thinking about it immediately in my head, and I understand the logistical issues that you can actually have with that. And with regards to removing clothing off patients, I think if you equip people with a tool, and there's plenty of tools around that have got a hook type process, but on the inside of the hook is a sharp knife, so hook into the clothes and just pull straight down, which should be able to open things up and then apply pads easily. And I would assume you would just turn the patient on their side. But obviously that carries its own risks, because some of the patients are really heavy, so there'd be some great data that would come out of that with regards to time of pad application and firing up the monitor for the first defib. But I'm sure you are well and truly all over that. Would that be right?
Sounds a bit like an autopsy, Shep, doesn't it? When you just hope
you don't
cut too quickly.
Yeah. But it's very impressive, see, the way that there's always a trial going on, and that might potentially frustrate the clinicians on the road. If I could just say, I mean, we know from research, if you do a randomized controlled trial comparing a new treatment to the standard of care, the group in the standard of care do better than people who just aren't in a trial but get the current standard of care. So just being part of a trial, like, it elevates the game. People on the money, they do things right, they document things correctly, and so always having a trial on the go, even if it's not really sort of, that based on anything meaningful would be valuable.
Yeah, you're spot on. And the other thing that I would say as well, Alex, is that, our young and emerging clinicians, particularly our intensive care that are intensive care trained, are really leading the charge around clinical trials. And I said that I would talk about our PANDA trial today as well, just to give PANDA a bit of a plug. They have taken and embraced PANDA leaps and bounds ahead of other trials, and the amount of enrolments that we're seeing is so impressive. And so you look at the current academic literature, completing a cardiac shock trial is incredibly hard within a decade because the patients are just so difficult to see. But we're actually tracking incredibly well, and it's really, again, taking my hat off to our colleagues for being able to enter these incredible scenes where the patient is really unwell. And one of the first things that they think about is opening an envelope and randomising a patient to a clinical trial. And that's pretty impressive. And about 60% of patients enrolled in the PANDA trial, which is a trial of cardiogenic shock patients receiving either adrenaline versus noradrenaline or epinephrine versus norepi, about 60% of those patients are post-cardiac arrest patients. And one of the immediate things our clinicians are thinking about at that sort of peri-ROSC state is, how do I maintain perfusion? And if they can stop that for just a moment and open an envelope, and the envelope decides what the treatment is, and that's pretty bloody impressive given the limited resources that we face in the pre-hospital setting. But they're just doing exceptionally well, and it just means that we can finally answer this sort of question about what is the optimal vasoactive agent for cardiogenic shock patients, and in particular post-cardiac arrest patients. And of course these little pandas have shock, think panda. That's come straight from our marketing team. No, I'm just kidding. But just to get the guys to think about the importance of randomising patients in clinical trials.
Mate, I love it. We'd have to have you back to have a chat just about trial names and how to come up with these names and where they're from. But it's great to see that there's research right across the spectrum. I think, people, they read a BACAR report and the public might think it's just about cardiac arrest, the tip of the iceberg. But you're doing stuff all the way, the cardiogenic shock, which is both pre and post arrest, and then stuff on STEMI and NSTEMI, and down to people with chest pain. You'll soon be taking over my GP work and doing trials in high cholesterol and just AV turn up, no, but it's great to see, you're minimising the number of arrests as well as treating the ones that happen better. So hats off to you. Great work.
Thank you. Well, that's the plan, and actually for the first time in our history, while we've dipped our toes into many serious conditions from stroke to major trauma patients to cardiac arrest and acute coronary syndromes, for the first time rolling out a trial of point of care troponin testing. It's called Accelerate Chest Pain. The whole idea is to accelerate the early diagnosis of patients with chest pain, to risk stratify patients with low risk chest pain, and to consult with our physician colleagues through the virtual emergency department to determine whether transport is always required in those cases. And that's really for the first time taking us away from our usual clinical trial program, which focuses on serious conditions, to look at the other end of the spectrum and determine what alternative care pathways are available from a pre-hospital perspective for patients who are experiencing just our textbook garden variety presentation that we see every day, such as chest pain.
No worries. See, I'm very mindful of the time here, mate, and I know you need to get off very soon. So I think we've got a couple of rapid fire questions that we might throw at you, mate.
Yeah.
What is something in medicine You've completely changed your mind about.
What is something in medicine I've completely changed my mind about?
This guy's been open to the evidence from the start. Now go ahead, mate. Yeah.
What have I been wrong about? A lot of things.
Lots, really.
I'm just trying to think of. Look, I don't know what have I changed my mind about?
Answer.
I don't know. How about the next question, Shep?
Yeah, no.
I've never seen you not be able to answer a question. This is actually impressive. I'm going to record this on my phone at the same time.
Yeah.
So how
No,
about
you've
this one, mate?
never been entrenched in one way. This is the way it has to be, you know?
Look,
Do not give GTN to right ventricular infarcts. There'd be people
well.
who have that tattooed on their arm, and then there'd be people like you.
Well,
Maybe
that's a
not.
session on itself. I'm not convinced that that's the case, but I appreciate that there might be some new schools of thought, but I'm not necessarily sure those schools of thought are born in evidence, actually. And that's a group of patients that I would continue to be incredibly cautious in. Look, maybe
100%.
it is absolute clinical dogma. Maybe it is, but... Well, let me tell you what I have changed my mind about. Many of you will know, I think probably one of the biggest changes for paramedicine has been the change of oxygen administration. 15 years after running the air versus oxygen in STEMI trial in Victoria, it is just beyond belief that you work with so many colleagues who just didn't grow up in the era of hip and shouldering people out of the way to get an oxygen mask on someone's face. And that's what we did. We basically did that before we introduced ourselves. That's how prolific that intervention was. And we'd go through cylinders of oxygen every single day. But I actually thought oxygen might in fact be beneficial for patients. And of course, we've got now several decades of science across the spectrum of emergency care and intensive care settings, basically suggesting that more is not necessarily better. So a pretty impressive area of science that has changed very quickly.
I think that was a massive one, and I still feel that attending to patients now, it's something that they seek. It's like, why don't you give them oxygen? They need oxygen, and it's not indicated unless in certain circumstances. So I still feel that understanding clearly is not there amongst the community as well at the moment. So definitely a big change that was.
Awesome. I see we've got some students and junior clinicians listening to this, and we ask senior people with a lot of experience like yourself, if you were to start studying medicine or paramedicine tomorrow, what sort of some advice you would give yourself? How would you approach it?
I'd say don't stop. Many people know my story. I didn't get a job straight away with the ambulance service. I was a bit too young. I still had to put my P's on the ambulance in order to get a job in Victoria. And so I got knocked back, and the worst thing that happened was I started an honours degree, and I reflect on that now, 20 years later, and it's delivered so much passion and love and prosperity to my life. I would say to people, when you finish your degree, whatever your passion is, just chase that, and make sure you're on the train, and you never know where it'll end up.
I think probably worth to mention that I think I saw something today that Mal Boyle was one of the people that helped you out in your earlier years, and he's actually just announced his retirement and moving away from university education. So hats off to Mal Boyle and everything he contributed to the profession over the years. But I am mindful of the time. So we've only got 4 minutes left really until we need to go. But before you do, and I'm sure you've seen, everybody gives us a little dance, which we
really
put in. Yeah. So we need 5 seconds of your best moves. And I know you need a dance floor and a polished bit of vinyl, but you're going to have to make a sacrifice today for us, mate. Let's 5 seconds of your best dance moves, mates. Get up.
Understood.
A bit of tango with the panda.
Yeah, there he is. We've got him. This is going straight to the AB media page.
That's right. I see, can we change the name Defibrillation, okay? Fibrillation, they're not all in VF, some of them are in VT, and some people get shocked, And then it's too technical. People, if we want them to use it, it's got to be called a heart starter.
I'm with you. I'm with you.
Not a AED, an automatic external defibrillator. I mean, automatic, of course, because there's no health professional there to sort of analyse the rhythm and do external. Crikey, of course, who's going to split open the chest on the side of the road to put some defibrillator pads around the heart? This is crazy just to include that in the name.
I'm with you, mate.
Defibrillators, so
I'm with you. Let's start a group. I think you're spot on. Every time I speak to the media, it's incredibly awkward to talk about an AED or defibrillation. I think the general public, these are not general words that people necessarily remember. We're doing our best to try and embed AED as a sort of common language, but it is a hard word to remember. The abbreviation doesn't really sit very well for lay people, and the heart starter, although that language is not generally used in Australia, it's used internationally. So I'm with you, mate. If you start up a group, I'll join you.
That's got to go on the pre-hospital nerds t-shirts.
Yeah,
absolutely.
Now you've got access to, all these people who come up with Panda and all these perfect mnemonics. So, all right, we'll tackle the AED next, brother. Yeah. Now we've got to have you back soon, talk about some exciting trials that's coming out in a few months' time. Thanks so much for your time.
Thanks, gentlemen. Great to be with you.
Thanks, Ed. Good to see you,
Thank
mate.
you.
Take care.
Yeah, likewise.
See you, buddy.
See you guys. Bye.
Cheers.
Bye-bye.